This is JAPI, and welcome to JAPI Podcasts.
Welcome to the JAPI podcast of the August 2024 issue of JAPI, Volume 72, Issue 8. This issue of JAPI has some really interesting articles, including 10 original articles, 2 review articles, also one consensus statement. There are also 11 case reports, 1 point of view, 2 letters of correspondence. Let's discuss all these things in details. The first original article is on blockades in the pathway of specialty care in rheumatoid arthritis. A report based on Indian Rheumatology Association database, Chandrasekhara S. et al. The study was a part of Indian Rheumatology Association database based on questionnaire format given to participants of 8 different rheumatology centers all over India. The aim of the study was to identify factors influencing referral patterns to rheumatologists in India and to know various reasons of delayed diagnosis, more than 6 months, of rheumatoid arthritis patients. In past, there has been reported studies on rheumatoid arthritis where it was found that the delayed diagnosis and delayed introduction of DMARDs, disease-modifying agents, may lead to increased disease burden and suboptimal outcomes. This study was a prospective, multi-center, observational study in which data regarding 6 common autoimmune diseases was collected with a performed pro forma. The data regarding socioeconomic and clinical profile was noted. The study included 4,643 rheumatoid arthritis patients diagnosed on the basis of ACR EULAR 2010 criteria. The study found approximately 1/3 of the patients received timely referral to rheumatologist, that is within 6 months of the disease onset. In the study cohort, 39%, while 26% got consultation with rheumatologists after 6 months to 24 months. It was delayed by over 2 years in 34% of the patients. The referral delays was linked to poor socioeconomic factors in some Indian states like Madhya Pradesh and West Bengal, lack of awareness among patient and family about the disease and rheumatology specialty, with highest in West Bengal, 100%, followed by Delhi and Rajasthan, 93%. And then misconceptions about modern medicine, reluctance to refer patients to their rheumatologist, and previous treatment by other specialties were another patient's factor influencing referral delay. Surprisingly, the primary care clinicians' unawareness of the rheumatology specialty was the primary reason for referral delay in 1/3 of the cases in Gujarat and 1/4 of cases in North Indian patients of Delhi and Jaipur, indicating need for updating knowledge of musculoskeletal disease through regular CMEs for primary care physicians. The article concludes that both patient and healthcare professional related factors contribute to referral delays in rheumatoid arthritis patients. Major factors causing referral delays include reluctance to refer and inadequate knowledge about rheumatology among primary care physicians and the general public. Patients' education and occupation also influence the timing of referrals to specialty care. There are limitations and drawbacks. In this study, the estimated prevalence of rheumatoid arthritis in India was reported 0.75 and thus affecting 5 to 7 million individuals in India, while the study population included 4,600 patients. Even the calculated sample size of 6,500 would not be achieved in this study. Therefore, the smaller sample size may not be a true representative of Indian population as a whole. There are only 2 out of 8 centers which were from public hospital. This may have played important role in observed final referral pattern in data. Considering majority of patients still consulting public or government hospitals for second opinion for specialist care in India, maybe have resulted in city-centric biased pattern of socioeconomic and referral pattern. But anyway, there is a positive from the study. The first from India conducted by IRA, national body, in 8 major centers. Also, the physicians also are aware now about this, and we want to create awareness among the primary health centers. And through this article, people will be happy to know that these sort of problems should be referred at the earliest. The physician factors in delayed referrals, social factors in rheumatoid artery management, and poor knowledge about musculoskeletal disease and rheumatology subspecialty among general population and primary healthcare physician should be rectified and must be creating an awareness for these people. Now coming to the next original article is on impact of immunoglobulin M enriched immunoglobulins on the outcomes of severe coronavirus disease 2019. Amit Goyal et al. Coronavirus disease 2019 led to a major global health crisis leading to a worldwide pandemic. The purpose of this academic work was to assess the efficacy of immunoglobulin M enriched Ig in the management of patients with severe COVID-19 pneumonia. In this retrospective cohort study, severe COVID-19 pneumonia patients who received IgM enriched immunoglobulin in addition to standard of care treatment were retrospectively enrolled. The eligibility criteria for the study included patients above 18 years of age who were diagnosed with severe COVID-19 pneumonia with a positive RT-PCR nasopharyngeal swab requiring ICU admission. Levels of inflammatory biomarkers, oxygenation status, and organ dysfunction were evaluated, and the differences were noted after giving IgM supplemented IgM. Data from 32 consecutive severe COVID-19 patients admitted to medical intensive care units were analyzed. After giving IgM enriched Ig, there was an improvement in oxygenation indices as shown by SpOT and bar FiOT on days 3 and 7. But it was not statistically significant. Oxygen support could be de-escalated in 40.6% patients on day 3 in 25% of patients on day 7 after giving IgM-enriched Ig. After giving IgM enriched Ig, there was a reduction in the levels of all studied inflammatory markers, SC as IL interleukin 6, D-dimer, and ferritin on days 3 and 7, but it was statistically significant only for interleukin 6. The overall ICU mortality was 53.1%. So it can be concluded that IgM enriching Ig may be helpful in improving oxygenation and combating cytokine storm in severe COVID-19 patients. However, in the present study, the improvement in oxygenation indices and reduction in inflammatory markers like D-dimer and ferritin were not statistically significant. Hence, larger randomized controlled trials are required to get more definitive evidence to support this therapy and show significant clinical and mortality benefits. Now we'll move on to the next original article. Utility of HACOR score in patients with acute exacerbation of post-tuberculosis obstructive airway disease, a retrospective observational study by Siddharth R. Wagmore et al. Post-tuberculosis obstructive airway disease, post-operative airway disease is a common sequelae associated with pulmonary tuberculosis and is a common cause of chronic OAD in India of smoking. After exacerbation of post-TB OAD, obstructive airway disease is characterized by acute worsening of symptoms and may lead to hospitalization. Hypoxia and respiratory fatigue are indications for hospitalization and respiratory acidosis. Type 2 respiratory failure can cause admission to the intensive care unit or high dependency units. Non-invasive ventilation is an important treatment modality in the management of patients with acute respiratory failure Some patients on NIV may still not improve and will require invasive ventilation, and delayed intubation may increase the risk of mortality. Therefore, it is very essential to correctly and timely identify the patients who would not respond on NIV ventilation, and many predictors have been used in this situation. One such scoring system is known as HACOR, which was developed to be used in critically ill respiratory disease patients. Duan et al. In 2016 developed HACOR score to predict NIV failure. HACOR score is an acronym for heart rate, acidosis, consciousness, oxygenation, and respiratory rate. H for heart rate, A acidosis, C consciousness, O oxygenation, and R is respiratory rate. So this HACR is an easy bedside score that requires minimal expertise and can be used in resource-limited settings, even primary settings. A score of more than 5 is suggestive of impending NIV failure. Of course, I told you this is a retrospective observational study done in total of 100 patients with acute exacerbation of post-TB OAD. In patients requiring up to or more than 2 days of NIV support, the trained HOCR score was calculated 12, 24, and 48 hours. In these patients, the difference between the score 1 and 48 hours was compared and satisfactorily analyzed with a significant level of 0.05. The results are a total of 100 patients with acute exacerbation of post-TB obstructive airway disease were included in the study. They all require NIV support. A total of 62 patients were successfully weaned off NIV, while remaining 32 subsequently required invasive ventilation. So the average HHCO score after 1 hour in the NIV success group was 3.88 and 9.47 in the failure group. At 1 hour of NIV, the number of patients with HACOR more than 5 in failure group was 34, was 8 in success group, while HACR scores was less than 5 in 4, less than 5 was in 4 in failure group versus 54 in NIVC success report. So, what is the discussion? The study utilized HACR score to predict the success rate of NIV ventilation in post-TB. The study compared HACR score at 1 and 48 hours in the two groups and found a decline in the HACR score in the NIV success group and an increase in the NIV failure group. Of the 38 patients with NIV failure, 26 patients needed intubation of 1 hour of NIV trial. Their mean HACR score was 10.98, and the HIV score were associated with NIV failure in other studies as well. The sensitivity of the HACR score of more than 5 at 1 hour in this study was the highest among the various studies, but the specialty was almost equal. The post-predictive value was lower than the observed by Duan et al., but higher than the obtained by Gia et al. The negative predictive value obtained in this study was the highest among these studies. The study has tried to assess the effectiveness of the HACR score in predicting NIV failure in patients with post-TB obstructive airway disease and has demonstrated a higher specialty and a negative predictive value in predicting NIV failure. Thus, the HACR score can be used to predict failure in post-TB OAD patients. Patients with scores of more than 5 need more frequent monitoring. Serial monitoring of the score help to assess the effectiveness of NIV treatment. An increasing score would be considered harbinger of impending NIV failure. So, bedside, you can find out through the HACR score. Now, the fourth original article, diagnosing signs and symptoms of cyanocobalamin deficiency at rural setting in India. Novel method of supplementation, Himoto Saluba, Bavaskar et al. The cyanocobalamin B2 or B12 deficiency is a common in the Indian population, prevalence ranging from 2 to 40%. The main dietary source of vitamin B12 are the meat, eggs, and dairy products. Therefore, vegetarians are more at risk. It is a cross-sectional observational study aimed to study the demographic profile, clinical spectrum of B12 deficiency, and dietary habits of patients. The study also assessed the B12 content of various types of food and the improvement of patients on adding B12 supplementation powder in the food ingested. A total of 1,992 suspected cases of B12 deficiency, females 50 to 70%, were clinically examined 50.75 and the male 49.94 were strict vegetarians, both vegetarians and non-vegetarians and strict vegetarians respectively. The commonest occupation associated with B12 deficiency included homemakers and service workers. The clinical manifestations include recurrent scalp hair loss, poor memory, tingling and numbness, generalized weakness. About 27.15 patients had pigmentation on the nail bed, knuckles, oral mucosa, and tongue, while 10.8% suffered from hypertension and ischemic heart disease. Additionally, studies where B12 content of fish, crab, unwashed and washed vegetables, curd, as well as 3 different types of meal, pre-cooked and post-cooked. Highest B12 content was found in black crab, and B12 was not detected at all in curd. It was noted that during the process of preparation of vegetarian and non-vegetarian food, there is 38 to 48% reduction in vitamin content. Most fruits and vegetables, when washed and stored in freezers or cooked in high-pressure cookers, result in total loss of B12. Antacids, PPIs, and metformin also are culprits in hindering absorption of B12. So, to conclude, the prevalence of B12 deficiency is 50% in the study population in Maharashtra, depending on dietary habits, cooking patterns, and occupation and drug intake. In the absence of laboratory investigations in rural settings, clinical signs and symptoms are helpful in detecting B12 deficiency. Authors opine food fortification and vitamin B12 powder, similar to table salt, to cooked food improved blood vitamins levels and hemoglobin. Now, the fifth article, total antioxidant status and oxidative stress in patients with COVID-19 infection, Mohit Jindal et al. What is oxidant status may have an effect on severity of COVID, however, studies are limited. A prospective observational study conducted in the Department of General Medicine and Biochemistry at Government Medical College Hospital, Chandigarh, which is a tertiary care hospital. 40 adult patients who tested positive for SARS-CoV-2 by RT-PCR and moderate or severe category pneumonia were included. Inflammatory markers, LDH, CRP, serum ferritin, D-dimer, total antioxidant capacity, and oxidant stress as measured by melanodiethyl, that is MDA, were assessed within 24 hours of admission. All 40 patients received standard treatment like steroids, low molecular heparin, and 10% received remdesivir. None of the patients received tocilizumab therapy. Inflammatory markers and oxidant status were measured at 12 weeks. The study showed that elevated inflammatory marks, high-level oxidative stress measured by melanodiethyl test, and low-level total antioxidant capacity is closely related to severity of COVID, and these parameters improve after recovery from COVID. Now, the next original article is also related to COVID and is on assessment of thrombotic complications among coronavirus infections. 2019 positive hospitalized patients at one government tertiary hospital center at Gujarat, a retrospective observational study by Rakesh Sharma et al. Study risk factors of thrombotic complications COVID 2019 pneumonia. Study progression of thrombotic complications after COVID-19 pneumonitis and its outcome. The study design, retrospective observational study conducted for a period of 1 year with sample size of 50. Inclusion criteria, all patients above 18 years, reverse transcriptase polymerase chain reaction or rapid antigen test confirmed COVID-19. The commonest age group was 46 to 55 with 32% of cases. The two most common underlying risk factors were diabetes and hypertension. Deaths were commonly seen in the age group 56 years and above compared to age below 56. The death rate was significantly higher in diabetes than non-diabetics, hypertensive than non-hypertensive. Now, higher the CRP value, more was the mortality. Death rate was lower in patients who were thrombolyzed than who were not in both pulmonary embolism and myocardial infarction cases. So to conclusion, the commonest age group affected with COVID-19 pneumonia was 45 to 55. The two most common underlying risk factors were diabetes and hypertension. Three most common presentation of patients with were thromboembolism followed by CV and MI. Around 22% died during course of treatment. Deaths were more commonly seen in the age group above 56. Death was more in diabetes and hypertensive than non-diabetic and non-hypertensive. CRP value was higher in patients who died in those who survived. Now comes the other original article, study of association of infection-related biomarkers and inflammatory cytokines with the severity of coronavirus disease 2019, a prospective observational study. Ramakrishna et al. The link between sepsis biomarkers and inflammatory cytokines in severity of COVID-19 is well established around the world, but there is little evidence available with respect to Indian population. So the main objective of the study is the relationship between the sepsis-linked biomarkers and inflammatory cytokines IL-6, C-reactive protein, ferritin, and D-dimer. The study was conducted in a tertiary care hospital in Pune, Maharashtra. And this study showed significant association between infection-related biomarkers and inflammatory cytokines such as CRP, D-dimer, ferritin, and IL-6 at admission, and these severity and outcome of COVID-19 infection. Study also showed that patients with severe disease also had increased length of stay in ICU and hospital. These patients with severe disease also needed HFNC, NIV, and mechanical ventilation, and increased mortality. Now, the 8th review article is on spontaneous intracranial hypotension, role of computed tomography guided cervical epidural blood patch. Sharad Ghat et al. The aim of the study was to analyze the effectiveness of CT-guided cervical epidural blood patch for management of spontaneous intracranial hypotension. Retrospective data was collected in the study from March 2009 to 2020 with the inclusion criteria of clinical syndrome of CSF leak, headache coming on shortly after resuming direct position and relief achieved by lying down, CT myelography evidence of CSF leak and cervical region, patients not responding to conservative management for 7 days. In conclusion, the study, computer tomography guided cervical EBB provides optimal results for patients with SIH due to cervical dural leak. It is feasible, safe, and durable with single session often sufficient. It has high success rate than lumbar EBP. Now, the next original article is on association of insulin resistance with pregnancy-induced hypertension by Abha Gupta et al. Preeclampsia is one of the most important causes of maternal and fetal mortality and morbidity. One of the risk factors for development of diabetes in insulin resistance. The aim of the study was to evaluate association of insulin resistance with pregnancy-induced hypertension. Data from 70 pregnant females who had completed 20 weeks of gestation developed pH were analyzed and compared with 30 appropriate non-normotensive controls. Out of 70, 24 were in the preeclampsia group, 46 in the eclampsia group. All females underwent measurement of fasting glucose level, fasting insulin level, and blood pressure. Insulin resistance was measured using HOMA-IR index. So, The results were the mean age of the women, the control group was 26. In the control group, 50% of women were primigravida, 50% were multigravida, and the mean IR among the control group was 1.37 in preeclampsia. It was 2.11, and in eclampsia, it was 3.58 with p-value of less than 0.001, which is very highly significant. In this study, the severity of the disease found to be directly proportional to insulin resistance. So conclusion, according to the current study, pregnant women with preeclampsia and eclampsia typically exhibit higher levels of insulin resistance than normotensive pregnant women. The study also highlighted the age-independent nature of the association between pregnancy-induced hypertension and insulin resistance. The current investigation demonstrated direct relation of insulin resistance and PAH severity. Thus, regular screening of preeclampsia women for insulin resistance, diabetes, and vascular disorders is highly recommended. Now, the last original article in this issue of August issue, haplotype-based analysis of 6Q2425 for association with rheumatoid arthritis by Liaquat Ali Gowthry et al. Family history of rheumatoid arthritis is an important risk factor strongly linked with inherited HLA-DR4. The aim of the study was to conduct the haplotype-based analysis and its associated rheumatoid arthritis. It is a case-controlled study which include all patients attending our outpatient department. In the study, we concluded that short allele of MOR gene, irrespective of being wild type or mutant variant, offering protections from the risk of developing rheumatoid arthritis. However, analysis of the long allele along with A11AG showed marginally increased risk of rheumatoid arthritis. Further, larger sample size with different cohorts are needed to confirm the findings generated in this study. Now, we are going to the review article. Interesting review article by medical negligence by postgraduate students and residents, the liability trial by Sadanand B. Naik et al. Postgraduate students or physicians in training are bound to make mistakes in medical negligence litigation involving the postgraduate students, the supervising faculty members, as well as the hospital where the alleged act has occurred would also be found liable. In this review article, the applicable legal principles and the brief summary of the case laws are presented. I encourage all our listeners to read this article since it gives interesting examples of cases, because day to day you need to know this. In the liability trial concerning medical negligence caused by postgraduate students, the responsibility begins with them and ends with the dean of the medical college or the hospital head. However, despite existing legal principles and doctrines, court judgments have been unpredictable and confusing. Postgraduate students, teaching faculty, and the institution should collectively ensure safe and appropriate patient care. The PG student should seek guidance and supervision from their respective teaching faculty. And the faculty, in turn, are legally obliged to provide such supervision to avoid vicarious and direct liability for negligent supervision. Having professional liability coverage not only for specialists but also postgraduate students, along with nursing and non-medical professional personnel, is of great help in times of adversity. Though nothing can prevent a patient from suing medical professionals, adhering to legal principles and norms can at least alleviate the stress and the anxiety associated with medical negligence litigation. It also puts one in a good position to defend against claims. It is imperative to establish a legal framework in the form of legislation to protect residents, postgraduate students, and allow them to focus on their training programs without the fear of litigation, while also being aware of their limitations while treating patients. We have one more interesting review article on life and times of Elapargada by Subbarao, Sunita, Kaidi et al. I also request everyone to read this article, also very interesting article. Despite numerous medical advancements made by Subbarao, awareness in the scientific world regarding his life and many contributions remains under-recognized. This article discusses Subbarao's life, academics, and achievements in a nutshell. We also have a consent statement published in this issue titled as Navigating Cardiovascular Risk and Lipid Management in Indian Patients. Key message from the Lipid Association of India 2024, Consent Statement 4, Ramanpuri et al. The Lipid Association of India in 2016 proposed an atherosclerotic cardiovascular disease risk assessment algorithm, an LDL cholesterol goal of less than 50 milligram per deciliter, which was proposed along with diabetes with two or more major ACVD risk factors or target organ damage, and homozygous familial hypercholesterolemia were included. The revised LAI recommendations in 2020, the extreme risk group was added in the risk. This was to suitably address the increased risk of experiencing future cardiovascular events due to severe or extensive ACVD risk with multiple CV risk factors or comorbidities. It incorporated evidence-based protein convertase subtile type or PCSK9 inhibitor monoclonal antibodies along with statin therapy, further reduction of CV risk. Guidelines categorically state that first priority is to lower LDL. Second priority, reduction in non-high density lipoprotein cholesterol or non-HDL and apolipoprotein B, ApoB. The third one is lifestyle management for controlling modifiable risk factors, comorbidities, and secondary causes of dyslipidemia. Statins remain the drug of choice, followed by SWB and bempedoic acid. PCSK9 inhibitors for those who do not attain recommended LDL level. If non-HDL cholesterol is above the goal, omega-3 fatty acids, preferably icosapentail ethyl and phenobarbital, are considered in addition to maximally tolerated LDL-C lowering therapy. Now, recommendations. LDL should be the primary and non-HDL should be the secondary treatment targets. Screening should start at the age of 18 for premature ASCVD. Family history of premature CAD is considered a high-risk future warranting an LDL cholesterol target of less than 70. NAFLD with fibrosis grades 2 and 3, metabolic syndrome, CKD, ApoB greater than 130, lipoprotein A 50 milligram or higher, coronary artery disease, coronary artery calcium score of 1 to 99, less than 75th percentile for age, gender, and ethnic group, and extreme elevation of a single risk factor or other high-risk features that place the individual in the high-risk group with an LDL target of less than 70. Diabetics to be initiated on dyslipidemia on day 1. Recurrent acute coronary syndrome or polyvascular disease, extreme risk group, a target of 30 milligram or lower is recommended. Patients with calcium score, CAC score of 1 to 99, but less than 75th percentile or high risk of with an LDL-C target of less than 70. Coronary calcium score values greater than 70th percentile with CAC 100 and 299 are classified as a very high risk group with LDL target of less than 50. CAC score exceeds 300, then the individual falls into extreme risk group A with an option of LDL-C target of 30 or lower. Heterozygous familial hypercholesterolemia without ASVD is included in the very high risk group with the LDL-C goal of less than 50. HeFH with ASCVD is included in the extreme risk group with an optimal LDL target of 30 milligram or lower. Conclusion. These latest recommendations will facilitate more appropriate dyslipidemia management among Indian subjects, leading to a reduction in CV risk. At the same time, the LAI, the Lipid Association of India guidelines, also emphasize the comprehensive ASCVD risk reduction and management beyond just lipid lowering therapy. Thank you, my dear brothers and sisters, for listening to JAPI podcast. I will get connected again in the future. Uh, Happy learning, happy listening, and happy spreading the knowledge. Thank you.